and thank you for joining this training webinar for BHIN number 25-008, which is about state law updates to the narcotic treatment program, also known as NTPs. My name is Millie Patel, and I am with Aurora Health Group. Today, we are helping DHCS facilitate this webinar. Our presenters today are Crystal Sanchez, who is the branch chief of the Licensing and Certification Division at DHCS, Monique Garcia, who is the section chief of the Counselor and Medication Assisted Treatment Licensing and Certification Division at DHCS, and Roberta Rankin, Rajneeshi Naiker, and Brandon Green, who are supervisors within the Counselor and Medication Assistant Treatment section. Next slide, please. Today's meeting materials will be recorded and DHCS will make it available at a later date. There will also be a Q&A session at the end of today's presentation. If you have any questions throughout the presentation, please enter them into the chat as we will be reading and organizing them throughout the webinar. Next slide, please. And I will now pass it over to Crystal to go over Assembly Bill 2115.
Thank you, Millie. And thank you everyone for joining us today. So to go over this slide, AB 2115, it requires DHCS to amend state regulations to comply with the final rulemaking of federal laws that govern opioid use disorder treatment in our licensed NTPs. This bill also requires DHCS to formally promulgate regulations and update them by April 30th, 2029. So we wanted to call out a couple compliance requirements. NTPs that choose to comply before October 1st, 2025 shall adhere to BHIN 25-008 and must submit an amended protocol amendment, written statement, and DHCS protocol amendment form 5135 within 30 days after the date the protocol change becomes effective within the licensed NTP. And then all NTPs have to adhere to this BHIN no later than October 1st, 2025. Therefore, all NTPs must submit an amended protocol, written statement, and DHCS protocol amendment form 5135 to DHCS demonstrating compliance with the regulatory changes in this BHIN no later than November 1st, 2025. To implement sooner, DHCS, we utilized our BHIN authority granted under AB 2115, and we issued this BHIN last month to comply with the federal law changes while we work on promulgating regulations, which is why we're all here today, so that we can provide you an overview of these new NTP guidelines and to answer any questions that you all may have as you are working on updating your protocols to show compliance. Next slide. So I want to go over some of the new definitions. New definitions were introduced in the final rulemaking to 42 CFR Part 8 and therefore are a part of the updates made to these new state laws. This slide covers definitions such as behavioral health services, which means any intervention carried out in a therapeutic context at an individual, family, or group level. Interventions may include structured, professionally administered clinical interventions such as cognitive behavioral therapy or insight-oriented psychotherapy that have been shown to facilitate treatment outcomes or non-clinical interventions. Diversion control plan, which is new as well, is a set of documented procedures that reduce the possibility that controlled medication will be transferred or otherwise shared with others of whom the medication was not dispensed to. Additionally, the diversion control plan, it must assign specific responsibilities to program staff that will carry out the diversion control measures and functions as described in the plan. And then care plan, which we all know formally as treatment plan, means an individualized treatment and or recovery plan that outlines attainable treatment goals that have been identified and agreed upon between the patient and the NTP counselor. The care plan specifies the services to be provided, including the frequency and the schedule for such services. And then we'll jump into harm reduction, which means a practical and legal evidence-based intervention to prevent harm, reduce risk, and promote health, which includes, it could be overdose education, screening and intervention for infectious diseases, including counseling, and risk mitigation activities, formerly known as, or forming a part of comprehensive integrative approach to address HIV, to address hepatitis, sexually transmitted infections, and bacterial and fungal infections. This also includes distribution of opioid overdose reversal medications and linkages to other public health services, and even connecting patients who have expressed interest in peer support services. Many of you are already implementing harm reduction services in your programs through DHCS's naloxone distribution project, and also by distributing fentanyl test strips through that project as well. And then interim treatment, which is new in California, that means on a temporary basis, a patient may receive medication for opioid use disorder from a NTP while awaiting access to comprehensive treatment. However, not to exceed 180 days in any 12-month period. And then medication for opioid use disorder. This really just means any medications that have been approved by the FDA to treat opioid use disorders, including methadone, naloxone, buprenorphine, and buprenorphine products approved by the FDA, and then any other medications approved by the FDA for purpose of OUD treatment. And I did want to note that we did remove LAM from this list because that medication is not utilized in the United States, and it was also removed from 42 CFR Part 8 federal laws. And then opioid use disorder means any cluster of cognitive, behavioral, and physiological symptoms associated with a problematic pattern of opioid use that continues despite clinically significant impairment or distress. And lastly, which we're excited to add to our new definitions, is telehealth. So that has the same meaning as defined in section 2290.5A of the Business and Professions Code. However, telehealth, as referenced in this BHIN, are only to synchronous interaction, and it does not include asynchronous store and forward transfer. Next slide. So on this slide, I'm not going to go over each of these definitions for the sake of time, but we did remove and revise several of the terms within our definition section due to outdated terminology, and we also updated these terms throughout our BHIN as well. So we won't dive into each of those changes as we go through the changes in each section, but we'll more focus on like the day-to-day operations. And then due to several stakeholder comments received, I did want to flag that a statutory change is needed in order for us to update our regulations. So that way we can start utilizing opioid treatment program in lieu of narcotic treatment program. And then in addition, in order for us to reference or utilize withdrawal management in lieu of detox, that would also require a statutory change. So those terms were not updated in this behavioral health information notice. Next slide. So let's jump into medication units. This chart briefly describes the services that are provided between the NTP and the medication unit. In alignment with 42 CFR Part 8 medication units, they may provide the full array of NTP services now. So essentially, any services that are provided in the NTP, they can be provided in the medication unit, only if it meets applicable laws and requirements, and of course has appropriate privacy and adequate space. So medication units, they allow patients to access OUD treatment in areas that are more geographically convenient for them. The primary NTPs, that serve incarcerated patients, they may consider opening up a medication unit within a correctional facility, so that way they can increase access there, as there is a high prevalence of OUD for this population, and increased overdose rates upon release for the incarcerated population as well. And then I just wanted to call out a couple of forms if you are wanting to expand the services within your existing medication units. So the DHCS 5025, that's our facility and geographical area form. That will include necessary information such as including and identifying counseling space, physical exam space, and assessment space. And then existing MUs will also need to submit a DHCS 5135 protocol amendment form. So that way they can expand services beyond the dispensing of medications and urinalysis tests. And then I want to also really emphasize that the primary NTP is responsible for providing all required services if the MU is not able to provide such services. So we want to make sure that the patients are able to access all required services. Um, and then that concludes my slides. I want to go ahead and pass it on to my colleague Roberta, and she's going to take a deeper dive into interim treatment services, which is optional and also a new service in California.
Okay, thank you. And good afternoon to everyone. I will begin with section 10023, interim treatment approval requirements, which is a newly added provision in the updated state regulations. So what is interim treatment? It is a temporary form of treatment provided to individuals with opioid use disorder when comprehensive treatment is unavailable within a reasonable geographic distance or when they are in urgent need of care. Interim treatment helps stabilize the patient by using medication-assisted treatment, typically with methadone or buprenorphine, until a patient can be transferred to a full treatment program. I would also like to point out again that NTPs are not required to provide interim treatment. An NTP that is approved to provide interim treatment may admit a patient into interim treatment only if comprehensive treatment is unavailable to that person within a reasonable geographic distance within 14 days of the date on which the person sought admission. In other words, if a patient presents to an approved NTP and that NTP does not have licensed capacity to admit the patient into comprehensive treatment, and no other nearby NTPs can do so either within 14 days, and the NTP can admit that patient into interim treatment. If the NTP has a slot in comprehensive treatment, then it must admit the patient into comprehensive treatment. An NTP that has a slot in comprehensive treatment cannot admit a patient into interim treatment to avoid completing the care plan within 14 days following admission. The approval and application process requires NTPs to first get approval from SAMHSA and DHCS before they can offer interim treatment. This requires the NTP to submit an application and a detailed protocol amendment directly to DHCS to show how the NTP will comply with interim treatment standards, ensuring that comprehensive treatment capacity remains unaffected and that pregnant patients receive priority for admission and transfer. DHCS will then work with SAMHSA to obtain federal approval for the NTP to begin offering interim treatment services. The duration of interim treatment cannot last longer than 180 days, which Crystal mentioned earlier, within any 12-month period. If the patient is not transitioned to a comprehensive treatment program by this time, the NTP must document a plan for transfer well before the 180 days are up. Typically, this action occurs by 120 days. Next slide. Okay, for testing and notifications, during the interim period, the NTP must collect at least 2 body specimens from the patient to test for substance use. This ensures that the patient is remaining compliant with treatment and helps track progress. NTPs must also keep the department informed about the patient's status at various stages, such as within 30 days of admission, within 30 days of being transferred to another program, and within 30 days of being discharged from interim care using the new DHCS 4032 form. NTPs are required to submit its plan for continuing a patient's treatment to DHCS at least 60 days before the 100-day period ends to ensure that transition planning is in place. For patient care and services, NTPs are not required to develop a comprehensive care plan or provide full counseling services during interim treatment. However, crisis intervention services must be available for patients to address urgent mental health or substance use needs. Please keep in mind failure to comply with the interim treatment requirements, whether regarding treatment protocols or timely notifications, may lead to suspension or revocation of the NTP's ability to provide the interim treatment services. Next slide. Minor updates were made to section 10030, protocol for proposed programs, primarily technical and administrative updates that improve clarity, align language with clinical standards, and ensure more detailed program planning, especially regarding physical space and telehealth. Subsection 42B now requires programs to detail the facility diagram and corresponding narrative to specifically describe and identify the counseling, physical examination, and assessment spaces in addition to office space. This section also now requires submission of a diversion control plan with clearly assigned staff responsibilities to minimize the risk of diversion. Any details, and details on the days and hours telehealth services are offered, as these hours may differ from regular business hours. All DHCS forms referenced in this section have been updated with the revision date of 05/25. Please make sure you are using the most current form found on the DHCS website, being cautious to not inadvertently use old form versions that have been saved to personal devices. Any forms submitted to DHCS that are outdated will be returned. Next slide, please. Section 10031 outlines the regulations for when an NTP seeks to work with other service providers to deliver certain treatment services. This includes the use of external providers for specific medical or behavioral health services. By default, all medical and behavioral health services must be available at the NTP's primary location. However, the NTP has the option to partner with external providers if those services are not available on site, allowing for a more comprehensive treatment approach. In order to work with other providers, DHCS approval and a written agreement with the other providers are required. An example of this could be if a NTP contracts with another business to provide counseling services, or maybe a NTP contracts with a jail and the jail provides certain services like urine collection and required laboratory testing or the initial screening evaluation for admissions. However, for this scenario, the jail would need to be contracted with an approved lab that is recognized by CDPH. Written agreements are required between the NTP and external providers, for example, hospitals, correctional facilities, or long-term care facilities. These agreements must clearly outline the services the provider will offer, such as specific health or behavioral treatment services like counseling or physical exams, the conditions under which these services will be provided, ensuring that they are delivered under appropriate circumstances, outline policies and procedures for the external provider to provide services in compliance with federal and state laws, including confidentiality laws like HIPAA and the security of controlled medications, and policies and procedures for the external provider to provide documentation to the NTP so that the NTP can track the services being provided to each patient by the external provider. Next slide, please. NTPs cannot begin using an external provider's services until DHCS approves the agreement and a protocol amendment has been submitted. This ensures that the NTP and external providers are operating consistent and compliant protocols, under consistent and compliant protocols. To apply for approval from DHCS, the NTP must submit an application for protocol amendment form DHCS 5135, protocol amendment components as required by section 10035C, and the signed agreement with all involved parties, ensuring all providers are formally committed to the terms. The NTP is required to document any services provided by the external provider in the patient's file. This documentation ensures continuity of care and accountability, allowing the NTP to track the patient's treatment journey across various service providers. Next slide, please. This section clarifies the responsibilities of the medical director. The medical director must have at least 1 year of experience treating persons with opioid use disorder and is responsible for overseeing all the medical and behavioral health services provided by the program and compliance with all federal and state laws. The medical director may delegate all duties to program physicians or physician extenders as prescribed in the NTP's protocol, except 10110A and B. A is the oversight of all medical and behavioral health services in compliance with state and federal laws. B is the responsibility for hiring, evaluating, and managing medical behavioral health staff, leading continuous quality improvement, including annual policy reviews, and overseeing patient care and monitoring outcomes. With the expanded role of physician extenders, mid-level exception requests to DHCS are no longer required. Additionally, as we provide an overview of the changes, this expansion will not be called out for each section. However, their role was expanded throughout the sections in the BHIN. Next slide, please. In section 10125, counselors, subsection A was removed as the list of approved practitioners was restrictive and now includes exempt individuals per Health and Safety Code 11833. Also removed was subsection A to provide clarity that psychiatric technicians cannot provide counseling services unless they obtain registration or certification from a DHCS approved certifying organization. BHIN BIN 23-008 covers exemption from registration or certification requirements in accordance with AB 1860. The following individuals are exempt from registration and certification requirements. A graduate student affiliated with university programs in psychology, social work, marriage and family therapy, or counseling, who is completing someone who is completing their supervised practicum hours to meet postgraduate requirements, or an associate registered with the Board of Behavioral Sciences, or a licensed professional as defined by the department, for example, licensed physician, psychologist, clinical social worker, marriage family therapist, or intern registered with the California Board of Psychology. Additionally, this section was updated to expand and clarify language regarding documentation in personnel files. Programs are required to maintain written proof of each counselor's credential, which may include licensure, Board of Behavioral Sciences registration, enrollment in a graduate program, or certification or registration obtained under Chapter 8. All right, now I'm going to go ahead and pass it on over to my colleague, Rajeshni.
Thank you, Roberta. Good afternoon, everybody. So section 10165 was updated to modernize language and streamline documentation requirements. Outdated terms like addiction were replaced with opioid use disorder, and new references were added for behavioral health assessments and care planning. Physician extenders are now recognized as authorized to sign progress notes, medication orders, which expands clinical flexibility. The section now requires the documentation of the patient's initial and periodic behavioral health assessment results. Documentation of prior history of opioid use disorder was removed from this section. While documentation of prior opioid use disorder may still be noted in the record, it is no longer a required part of the admission criteria, which we'll discuss further in a later slide. Additionally, it is no longer required to justify why continued treatment is needed beyond 1 year for maintenance treatment. Documentation requirements for maintenance and detoxification have been aligned, so some subsections were reordered or consolidated to eliminate duplication. Next slide. Section 10210 and 10215 were updated to improve clarity around how programs should handle situations where a patient may be enrolled in more than one narcotic treatment program at the same time. Outdated language was replaced to reflect modern clinical standards. Terms like replacement narcotic therapy were removed and replaced with controlled medication for opioid use disorder, consistent with other updated sections and DSM-5 language. We've also clarified that detecting multiple registration at NTPs must be conducted before dispensing the initial dose of medication to an admitted patient, whereas previously the language stated before a program admits a patient for treatment. Patients will now be requested, not required, to sign a written statement documenting whether they are currently receiving the initial dose from another program and retain the statement in the patient record. And we've clarified that if the patient declines to sign the statement, the program shall document the declination in the patient's record and shall review the initial test or analysis for substance use to detect methadone or buprenorphine. The program may still provide initial dose of medication before the test results are received. So a declination does not mean that the patient cannot be admitted into treatment. Updates were made to clarify the timelines in section 10215. If the patient tests positive, or if they decline the test for substance use, the NTP must follow multiple registration process by contacting programs within a 50-mile radius. When contacting NTPs within a 50-mile radius, because the initial test results indicate the presence of methadone or buprenorphine, or the patient declines the test for substance use, the admitting NTP will do this within 15 days after receiving those results. NTPs receiving the request must determine if it has provided controlled medication for opioid use disorder to the patient within the past 90 days. Next slide. Section 10270 has been repealed and replaced in its entirety to reflect modern clinical standards. The updated text no longer mandates recording how long a patient has met opioid use disorder criteria prior to admission, reflecting a shift to focus on current clinical needs rather than duration of past use. Timelines have been updated to align with 42 CFR Part 8. A full medical history and physical examination, along with the initial behavioral health assessment, must be completed and documented within 14 calendar days of admission. The criteria for minor admissions has been clarified. Now, anyone under 16 years of age requires documented parental or guardian consent prior to admission. If a minor under 16 years of age requires admission into NTP treatment, a CSAT exception is required to be submitted. Pregnancy protocols still remain a priority, with the updated text specifying that pregnancy confirmation or signed waiver if the test is declined must occur during the initial intake. If a pregnancy test is refused and a waiver cannot be obtained, that declination must be noted in the patient's record. Next slide. Continuing with 10270, during the initial screening, the clinician must first confirm that the applicant has no contraindications to treatment with medication for opioid use disorder. Once safety is established, the screening proceeds to verify that the applicant meets at least one of the following maintenance admission criteria: diagnostic criteria for moderate to severe opioid use disorder, an active moderate to severe opioid use disorder, a history of having been in remission for opioid use disorder, or determination that the applicant is at high risk for recurrence or overdose. These criteria may exist independently or in combination. Under federal OTP guidance, individuals with mild opioid use disorders may be admitted into maintenance treatment if they're at high risk of overdose, particularly in today's fentanyl-driven environment. NTPs must therefore conduct a thorough history and examination to assess overdose risk. Additionally, patients with mild opioid use disorder or without physical dependence benefit from specialized education on methadone and buprenorphine pharmacology, so they clearly understand the distinction between physical dependence and opioid use disorder before giving informed consent. If the applicant is seeking detoxification, the screening must show that the individual either meets diagnostic criteria for an opioid use disorder or has an active opioid use disorder. Only after these eligibility checks, no contraindications plus one of the applicable opioid use disorder criteria, may the patient proceed to the next step in the admission process. Also, noting that a patient who is solely diagnosed as mild opioid use disorder may be admitted into detoxification treatment and move into maintenance treatment if deemed clinically appropriate by the medical director, physician, or physician extender, and shared decision-making with the patient. Next slide. Initial screening now includes a telehealth option, followed within 14 days by a full examination, which includes an in-person physical exam, a combined physical and behavioral health assessment, and any required laboratory testing. This sequence, screening via telehealth if appropriate, then a comprehensive exam and assessment, ensures timely integrated care under the updated regulations. If an admitted patient tests positive for tuberculosis, HIV, viral hepatitis, or a sexually transmitted infection, the NTP shall connect the patient to a healthcare provider who can provide treatment for the infection. An NTP is not prohibited from treating STIs on site. However, this would occur under the scope of an individual practitioner's license and is not an NTP service, nor permitted solely under NTP licensure. These simple steps will help ensure your program meets regulatory requirements and protects patient safety. Next slide. And finally, Section 10270 now clarifies how telehealth may be used for screening and assessment. First, a screening examination is required to confirm that a patient meets admission criteria and has no contraindications to medications for opioid use disorder. For buprenorphine treatment, that screening may be conducted via audio-visual or audio-only telehealth platforms. For methadone treatment, the screening must be conducted via audio-visual telehealth platform only, unless the patient is physically co-located with a non-NTP licensed provider during an audio-only visit. That screening may be performed by a non-NTP provider, such as a primary care clinician, but occur no more than 7 days prior to admission at the NTP. Once the screening confirms no contraindications, the patient may commence medication. For methadone telehealth screenings via an audiovisual platform, the medical director must determine and document that an adequate evaluation was or can be accomplished by video. Audio-only methadone screenings are permissible only if the patient is in the presence of a non-NTP licensed provider who is authorized to prescribe or dispense controlled medications. The medical director then reviews those results and orders medication as indicated. Behavioral health assessments follow the same rules: audio-visual only for methadone and audio-visual or audio-only for buprenorphine. Every patient must receive a full in-person physical examination regardless of medication. That exam may be conducted by a non-NTP licensed provider, but must be verified as accurate by a licensed NTP practitioner and transmitted in compliance with applicable privacy laws. I'd like to point out that although the Behavioral Health Information Notice 25-008 mandates that a telehealth screening allows the patient to receive dosing or take-home medication, the full physical exam must occur in person within 14 calendar days. NTPs are responsible for developing policies and procedures that ensure timely compliance with state and federal regulations to complete a full in-person physical exam within 14 calendar days following a patient's admission. To ensure there's no gap in regulatory compliance, consider practical fixes such as pre-scheduling every patient's in-person exam at admission with a firm due date, building an alert into your electronic health record or a paper checklist to flag the upcoming deadline. If needed, pausing additional take-home medication until that exam is complete, and tracking your compliance rate through internal quality assurance audits. Only under significant extenuating circumstances may state-only exceptions be requested and submitted. An example of an extenuating circumstance would be the patient becomes incarcerated or hospitalized after the first dose. DHCS or SAMHSA will not approve any request in situations where the program just did not complete admission requirements due to the patient simply not returning. And I will turn over the mic to Brandon.
Thank you, Rajeshni. It's actually my turn.
Okay.
And again, my name is Monique, and I will go over the next few slides, starting with section 10295, patient attendance requirements. This section was updated for clarity to specify that a patient may receive medication for opioid use disorder temporarily from another NTP if they are unable to access treatment at the NTP in which they are a patient. This section was also amended to include some examples, such as travel for work, family events, if the assigned NTP is temporarily closed, the patient temporarily relocates, or the patient becomes incarcerated or hospitalized. Temporary MOUD at another NTP is still limited to 30 days. However, flexibility was added for patients that are incarcerated, hospitalized, or in residential or long-term treatment. For one of these scenarios, the program may provide MOUD for the duration of the patient's stay without being required to submit a state-only exception request every 30 days. Roles were also expanded. Physician extenders were added as someone that may do a medication change order and permit a patient to receive services temporarily from another program. Next slide, please. Minimal changes to this section. This section was amended to allow more time that a patient may miss appointments before being discharged from the NTP. So a patient may miss 7 consecutive calendar days without notifying the NTP, after which the patient may be discharged from detoxification treatment. A patient is now required to be discharged from maintenance treatment if they miss 30 consecutive calendar days without notifying the NTP. Next slide. Section 10305, patient care plans. Previous subsections B and C, which were specific requirements for detox and maintenance treatment plans, have been removed. Care plans are now more patient-centered and aligned with shared decision-making to promote flexibility and creation of care plans that promote recovery activities like employment and education. Care plans must also include harm reduction interventions as needed. The care plan is required to be completed within 14 calendar days of admission as opposed to 28 calendar days, and is required to include short and long-term goals and mutually agreed upon actions for the patient to meet those goals in applicable areas of education, vocational training, employment, medical and psychiatric services, and psychosocial, economic, legal, housing, and other services. Previously, the care plan was required to have goals with estimated target dates not to exceed 90 days for the patient to achieve those goals. However, these target dates were removed, and it is up to the patient and the counselor to determine mutually. However, I do want to call out that care plans still do need to be updated a minimum of every 3 months. And as noted, the patient care plan is required to be developed and signed within 14 days of admission. Each subsequent care plan is required to be completed every 3 months from the initial care plan effective date. The frequency did not change. However, I'd like to call out again that the subsequent updates are required from the effective date of the initial care plan versus the patient admission date. Also very important, the effective date of the care plan is the date that the counselor signs the initial care plan. We will also be circulating a treatment plan diagram along with the FAQ to help provide clarity on care plan update requirements. We also did receive a couple questions around the needs assessment called out in this section, and just want to point out that the needs assessment mentioned in section 10305 little c is not a new requirement. This subsection was renumbered and amended slightly to include additional elements such as housing and inclusion of a behavioral health assessment. However, a needs assessment was always required and is still required. Subsection G was also added, which specifies that a NTP may directly provide vocational training, education, and employment services to patients. However, I do want to note that these services are not part of the GMC, DMC, ODS, NTP benefit and are not necessarily covered by Medi-Cal. If the NTP does not provide these services, they are, however, required to provide patients with referrals to accessible community resources. And next slide. This is a new section. Section 10306 was added to outline requirements for the annual physical examination. The medical director, program physician, or physician extender is required to perform an in-person physical examination of each patient at least annually from the date of the patient's initial or last physical exam. Annual physical exam should include all elements in 10270F1, which outlines full medical and physical examination requirements. Again, these elements include a review of the patient's medical and psychiatric history, including the patient's history of substance use, an in-person examination that includes serology and other laboratory testing, and counseling on preventing exposure and transmission of infectious diseases, as well as screening for those infectious diseases. The annual physical exam is also required to include a review and evaluation of items listed on the screen, which are a review of the last physical exam, the patient's care plan and medication dosing in response to treatment, as well as the patient's other needs, goals, and relevant physical and psychiatric needs and goals. The patient may decline to complete the physical exam or laboratory testing for co-occurring physical health conditions. If they do decline, the NTP cannot exclude them from treatment unless the declination will negatively impact the patient's treatment. Although the patient may decline these services, the NTP should be discussing the benefits of the services with the patient. The NTP should also come up with policies and procedures to ensure all required NTP services are done, including annual exams, care planning, counseling, and substance use and disease testing. If a patient does decline, the NTP is required to obtain the patient's signature on a waiver, or if unable to obtain the patient's signature, document the declination in the patient's record. DHCS will review waivers during annual inspections and waiver forms during initial application submissions. An example of waiver language would be which service was offered, the benefits of the service were discussed with the patient, that the declination will not negatively impact the patient's treatment, patient's signature on the waiver or declination documented in the patient's record, and qualified staff member's name, title, signature, and date. If a patient tests positive for tuberculosis, HIV, viral hepatitis, or a sexually transmitted infection, the NTP is required to connect the patient to a healthcare provider who can provide treatment. The NTP is not prohibited from testing STIs on site. However, if the NTP chooses to treat the STI on site, this would occur under the scope of an individual's practitioner's license and is not an NTP service, nor is it permitted solely under NTP licensure. The medical director, program physician, or physician extender is required to document the date and results of the annual physical exam in the patient's file. And I'd also like to point out that although the initial physical exam may be performed by an external provider, the annual exam is required to be completed by the NTP as specified in this section of the BHIN. Next slide. Section 10310, NTPs are now required to perform a random test or analysis for substance use of each patient no fewer than 8 times annually, except if a patient experiences extenuating circumstances. In this situation, the NTP must submit a state-only exception request to the 8 urinary drug screen requirement and document the patient record. A program can test at any time deemed clinically necessary as well. This section was also amended to specify that NTPs cannot discharge a patient because the patient declined to test or if the patient tests positive. A NTP can only discharge a patient if the positive test or presumed positive test will negatively impact the patient's treatment, If a NTP decides to discharge for this reason, the NTP is required to document evidence of increasing clinical risk to the patient's health and safety. If the patient declines to take the test, the NTP is required to obtain the patient's signature on a waiver, or if unable, document the declination in the patient's record. Lastly, this section was updated to specify the requirement to do 8 annual tests does not prohibit the NTP from distributing harm reduction supplies for a patient to test their personal drug supply for the presence of substances that may increase overdose. I'd also like to note that if a patient is unable to do a urine test and can only do saliva testing, please do not submit an exception request through the CSAT portal. SAMHSA does not specify the method of testing. The requirement for a urine drug screen is a state requirement mandated by the California Department of Public Health. Instead, this type of request needs to be submitted via the DHCS state-only exception form, and DHCS would only approve if the patient is unable to do so due to a physical limitation. And I would also like to reiterate, please do not submit any exception requests related to UDS through the CSAT portal. Next slide. Section 10345, counseling services. We do want to make it very clear that counseling is still a required service that NTPs must offer. Upon completion of the initial care plan, the NTP is required to offer the patient a minimum of 45 minutes of counseling per month. The minute requirement was updated from 50 to 45 minutes to align with billing intervals. This section was also amended to remove the requirement that counseling sessions be documented in 10-minute intervals to also align with billing interval requirements. Although the NTP is required to offer 45 minutes of counseling per calendar month, the patient may decline. NTPs cannot exclude a patient from treatment because the patient declined counseling. If a patient declines counseling, then the NTP is required to obtain the patient's signature on a waiver, or if unable to obtain the patient's signature, document the declination in the patient's record. Since counseling is required to be offered monthly, a waiver or declination is also required monthly if the patient chooses to decline. Counseling is required to include harm reduction interventions, psychoeducation, and recovery-oriented counseling. The requirement for the session to be face-to-face discussion was removed to allow for telehealth opportunities. This also means facility-wide exception requests are no longer required. However, a patient may request and have the right to do in-person counseling. And next slide, I will pass it over to Brandon.
All right, thank you. My name is Brandon. I'm going to be going over section 10350, which talks about the initial dose administration and observation for new patients. This section was updated to allow the program physician or physician extender to administer and or supervise the initial dose of medication used in MOUD. Section 10355, medication dosage levels. Physician extenders are now authorized alongside medical directors and program physicians to determine, adjust, and document medication dosage schedules. Detoxification tapering schedules must now be mutually agreed upon through shared decision-making with the patient and are no longer limited to 21 days. For maintenance treatment, each program is still required to have a protocol with the program's procedures on determining a stable dose. However, it also needs to include the patient's report of medication effects and dosage level preference, including changes in healthcare status that can affect medications, change in medications, pregnancy status, and concurrent substance use or alcohol use. The maximum first-day methadone dose was increased from 40 milligrams to 50 milligrams if clinically justified and documented by a physician's extender. A new medication order is required after a patient misses 4 or more doses, previously referred to as 3 or more. Next slide. All right, section 10360, pregnant patient requirements. This section was amended to specify the acceptance of medical responsibility for the patient's prenatal and postpartum care is required, including providing reproductive health services or verification that the patient is under the care of a physician, physician assistant, or nurse practitioner licensed by the state of California and trained in obstetrics or gynecology, or a licensed midwife or certified nurse midwife licensed by the state of California. If a patient declines a pregnancy test, the NTP is required to obtain the patient's signature on a waiver, or if the program is unable to obtain the patient's signature, the declination is required to be documented in the patient's record. Body specimen testing is required every other calendar week instead of weekly. If the patient declines prenatal care or referral, the program is required to document the declination in the patient record. Periodic consultations, at least monthly, are still required. However, they are no longer required to be face-to-face and may be with the medical director, program physician, or physician extender. Next slide. All right. Section 10365, take-home medication procedures, was updated to require each program to have procedures to identify theft or diversion of take-home medication. Also clarified that it can be for methadone or buprenorphine. Programs must now educate patients not only on safeguarding take-home medications, but also on safe transport, storage, and child household safety precautions, and must also document the education in the patient's record. Section 10370, criteria for take-home medication, was updated with criteria and considerations for take-home medication, and some requirements were removed. Take-home medication approval must reflect clinical judgment that therapeutic benefits outweigh diversion risks. Considerations include absence of an active substance use disorder or other physical or behavioral health condition that increase the risk of patient harm, regular program attendance, no serious behavioral problems that endanger the patient or the public, no known recent diversion activity, whether the patient can safely transport and store take-home medication, and other criteria that the medical director, program physician, or physician extender considers relevant to the patient's safety and the public's health. Section 10380, take-home medication procedures for holidays or weekend closures, was updated to allow one weekend day closure. The program may choose to close either Saturday or Sunday. Programs must ensure patients not approved for take-home medication still receive access via limited hours or courtesy dosing. If a program has patients who are not approved for take-home medication during holiday or weekend day closures, the program is required to maintain limited dispensing hours to provide medication to these patients during the closure, or arrange for courtesy dosing at another program. Section 10385, exceptions to take-home medication criteria and supply limits, was also updated. The request for exceptions to take-home criteria or methadone supply limits may now be submitted by the medical director, program physician, or physician extender. Patients must be safely able to manage take-home MOUD, not just responsible in handling narcotic medications, to qualify for an exception. In cases of natural disasters or emergencies, the department may grant additional exceptions following SAMHSA approval. Section 10390, revoking, reducing, and restoring take-home MOUD privileges, was also updated. This section was updated to expand responsibility. Program physician and physician extenders may revoke, reduce, or restore take-home medication based off criteria in 10370 and their clinical judgment. However, their rationale needs to be documented in the patient file. The medical director, program physician, or physician extender may reduce a patient's supply of take-home medication for the following: 1, positive body specimens; 2, inexcusable absence from appointments. Additionally, a patient's medication may be revoked based on criteria in 10370 or any clinical appropriate areas not limited to patients sharing, selling, trading, or giving away their medication, patients attempting to register at another program, the patient alters or attempts to alter their test for substance use, lest the patient is no longer a suitable candidate. The NTP is required to have a protocol for revoking, reducing, and restoring take-home medications. We would also like to clarify the guidance was recently received by SAMHSA. Only exceptions to medication requirements may be submitted through SAMHSA CSAT portal. Any exceptions unrelated to medication must be submitted via DHCS state-only exception form. If a patient does not qualify for take-home medication or clinicians are not comfortable prescribing it, programs must still ensure that medication is made through alternative means. We also want to emphasize it's up to the physician, the PA, or the MD to determine the amount of take-home medication an individual can have. If there are criteria that patients aren't meeting, it is up to the clinician's judgment whether or not they should reduce take-homes or not. Next slide. Okay. This slide outlines changes to take-home supply limits under section 10375, replacing rigid step levels with more flexible limits based on time and treatment and clinical judgment. New supply limits are on the screen. First 14 days of treatment, the take-home supply shall not exceed 7 days. From 15 days of treatment, the take-home supply shall not exceed 14 days. From 31 days of treatment, the take-home supply shall not exceed 28 days. The medical director, program physician, or physician extender must determine the appropriate take-home supply based on the criteria in section 10370A with the maximum limits above. If a patient transfers programs without a break in treatment, the new program may continue the take-home schedule based on the patient's treatment duration at the prior program. Methadone provided under holiday or weekend dosing provisions in section 10380 does not count towards the supply limits in this section. If a patient transfers to another program without a break in treatment, the new program can provide take-home medication up to what the previous program was providing. Next slide. Section 103860 is split dosing. The physician extender responsibilities were expanded, and they may now determine that a split dose is necessary. The section was also updated to specify a patient may receive their daily dose of medication split in 2 or more doses. We repealed section 1040 for streamlining. Previously, this section was included to explain the restoration of restricted take-home medication privileges. Section 10410, previously this section was included to explain the evaluation of a patient after a year in treatment. This section is repealed to align with section 10305, patient care plans, and 10306, annual physical examinations. Next slide.
Thank you, Brandon. We will now answer submitted questions. If you have any questions, please submit them through the Q&A box in your control panel. Our first basket of questions talk about physical exams. And we have a question saying, can they refuse the initial physical exam? Can they refuse subsequent physical exams for annuals?
I can go ahead and take that one. So the initial physical exam must be completed by the patient and the NTP. However, patients may decline the annual physical exam. So all patients that are enrolled in an NTP, regardless if they are receiving buprenorphine or methadone, so all patients, they're required to complete an in-person physical exam within 14 days of admission, which includes serology and other lab testing considered clinically appropriate by the healthcare provider performing the exam. The only portion that can be declined in the initial physical exam is the laboratory testing. So the patient can decline the lab testing portion of the physical exam, but if the patient does, then the patient needs to sign a waiver. And then if the program is unable to obtain a waiver from the patient, then the patient's declination must be noted in the patient record. Additionally, the NTP's medical director, program physician, and also the physician extender. So those individuals are qualified to perform an in-person physical exam. And that has to be done annually from the date of the patient's initial or last physical exam. And we did also want to make it clear that an NTP cannot exclude a patient from treatment, with medication just because the patient declined the annual physical examination or laboratory testing for co-occurring physical health conditions, unless the declination will negatively impact the patient's treatment.
Thank you for that response. We also have another question about the physical exam, and the question's asking if the full physical exam can be conducted by a corrections provider.
Yes. So long as that corrections provider is appropriately credentialed and qualified to conduct physical exams, and is performing functions within their scope of practice, a corrections provider can do the physical exam. I did want to further elaborate that, any non-NTP provider can perform the full medical history and physical exam within their scope of practice. And this goes for the initial physical exam. The full medical history and physical exam, it has to be done within that time frame, provided that the NTP documents its review and concurrence with the external provider's physical exam in the patient file. And then additionally, we just want to make it very clear that the annual physical exam, that has to be performed internally by the NTP. So it has to be done by the NTP themselves, while the initial physical exam can be conducted by a non-NTP provider. So there is a distinction there.
And for telehealth methadone admissions, if a patient does not complete the 14 calendar day in-person physical exam, despite multiple attempts by the OTP, should the OTP patient be discharged?
So we updated the patient's absence section to state that if a patient in maintenance treatment misses medication for 30 consecutive calendar days or more without notifying the NTP, then the patient's episode of treatment, it has to be terminated by the medical director or the program physician. And we made this change to give you all some flexibility and to reduce the amount of administrative discharges that we're seeing. We definitely do not encourage NTPs to discharge patients just to avoid regulatory issues. But instead, NTPs need to develop policies and procedures to meet the regulatory requirements. So with that said, at NTP's protocol, it has to include criteria and procedures for complying with patient admission requirements. So an NTP, they can develop policies and procedures to ensure intake requirements are completed within 14 days following a patient's admission. To do that, they can address in their PMPs, ensuring that appointments are made to ensure that the patient's physical exam, behavioral health assessment, and care plan development are done within 14 days. NTPs can also implement policies and procedures around take-home medication that encourages patients to come back to complete the intake requirements. So what we've been hearing is some of our NTPs are not providing take-home medication to patients unless they have completed all of their intake requirements. And of course, unless the patient meets the criteria and time and treatment requirements. So, in that sense, you're not really withholding the medication from the patient. You're just requiring the patient to dose in person until all of their requirements are met. And then also SAMHSA has made it very clear that exception requests to all of the intake requirements, that there only be, those will only be considered if there are significant or extenuating circumstances, such as like incarceration or hospitalization. But really, NTP should be completing these requirements within that 14-day time frame. So remember, before you all were required to complete these requirements prior to admission. This change just gives you all, the flexibility to schedule in time to complete these requirements. And then it's also just not so much that has to be done at one time for the patient. So it just makes intake on the patient a little bit easier as well.
Thank you for that response. And to further elaborate, there's another question about testing. Are there required tests such as HIV and HCV testing during the annual physical review?
Yes. So as part of the patient's physical exam, an NTP will order serology and other lab testing that they considered clinically appropriate. And they must offer the patient screening for infectious diseases, including tuberculosis, HIV, viral hepatitis, and sexually transmitted infections. If the patient tests positive for diseases, then the NTP has to connect the patient to a provider to treat the diseases that were identified. And then the NTP, they can also directly treat the patient who tests positive for diseases. There's no restrictions around that. However, we just want to make it clear that that would be done outside of the NTP's license, as this is outside of the NTP's licensing scope, but rather the treatment for these diseases that were identified would be provided under the clinician's individual license and within their own individual scope of practice.
Thank you for that response. Moving on to the next question. The question is, do we have to have policies offering patient waivers for pregnancy, UA testing, syphilis, and/or TB if our medical director still wants these to be required tests to participate in the program?
Yes, the program must have policies and procedures in place to complete these requirements. I would also like to make it clear that the initial UDS for admissions is required and cannot be waived. However, a program cannot discharge a patient because they decline to take subsequent urinary drug screens unless the positive or presumed positive tests will negatively impact the patient's treatment. An NTP also cannot exclude a patient from treatment because the patient declined laboratory testing for co-occurring physical health conditions unless also the declination will negatively impact their treatment. The NTP should explain the benefits of testing to the patient. If the patient declines the test that is offered by the NTP, then the NTP is required to obtain the patient's signature on the waiver. And if the NTP is not able to get the signature on a waiver, then they are required to document the declination in the patient's record.
And moving on to the next question. The question is, do exceptions to courtesy dose over 30 days, such as incarcerated patients, get submitted via CSAT or DHCS exemption?
So there's a two piece to this particular question. So, the 30 days, that is a state requirement and it is not outlined in federal law. So if a patient needs to receive medication on a temporary basis for longer than 30 days, then the patient's home NTP must submit an exception request to DHCS via the DHCS 1834 NTP exception request form. And that's only an exception request to state regulations only. However, a patient who is incarcerated, hospitalized in a residential or long-term care facility, they may temporarily receive medication from an NTP for the duration of their stay within, the correctional facility, the hospital, or the residential facility or long-term care facility. And then also the other piece of this is, if you are providing medication to, incarcerated patients, if that NTP wants to provide take-home medication to the incarcerated patient for their duration, however, the patient is needing take-home medication outside of the take-home supply limits, based off that patient's time in treatment, then the NTP is required to submit a CSAT exception because the time and treatment requirements are outlined in federal law. So there's a two-portion piece to that. So depending on the patient's circumstances, either a state-only exception would be needed if they're just needing to go past the 30 days. But if you're trying to provide medication past the 30 days or even less than 30 days, but the patient just doesn't qualify by meeting the time and treatment requirements, then a CSAT exception is needed.
Thank you for the clarification. We also have another question going back to annual lab testing, and the question's asking that if we are offering annual lab testing and it can be declined, does this include annual TB testing?
Optional screening for infectious diseases, including TB, are required as part of the patient's annual exam. However, the patient may decline to undergo annual testing so long as the declination will not negatively impact the patient's treatment. But also, again, if the patient does decline, a waiver is required or it needs to be documented in the patient's record.
Thank you for that information. We have another question about licensed professionals. The question is, do licensed professionals include LVN/LPTs who are allowed to provide counseling services and are exempt from needing to register with an AOD registration agency?
So the state plan currently allows LVNs and LPTs to provide counseling services because they fall under the definition of licensed professionals of healing arts. But I do want to further elaborate that NTP staff providing counseling services, they have to be either registered or certified by a DHCS certifying organization, or they have to be exempt. So they have to be one of those exempt individuals that are outlined under Health and Safety Code 11833. So the individuals that are exempt are graduate students affiliated with a university program in psychology, social work, marriage and family therapy, or counseling, who has completed their supervised practicum hours to meet postgraduate requirements. And then we did also issue a behavioral health information notice to provide more guidance around that. And then also an associate registered with Board of Behavioral Services. They're also exempt from registering or certifying with a certifying organization in order to be exempt. And then a licensed professional as defined in California Code of Regulations, Title 9, Chapter 8. And that is explicitly called out in section 13015. And so under that section, we define a licensed professional as a physician licensed by the Medical Board of California, or a psychologist licensed by the Board of Psychology, a clinical social worker or marriage and family therapist licensed by the California Board of Behavioral Sciences, or an intern registered with the California Board of Psychology and California Board of Behavioral Services. I did also want to flag that we're updating Title IX, Chapter 8 to update the licensed professional definition to reference Business and Professions Code Section 500, which will expand that list of exempt individuals. However, those regulations are not final, and we will share that language with you all to provide feedback before we finalize those regulations.
Thank you for that clarification. And we have a question about patients admitted for buprenorphine. The question is, for patients admitted for buprenorphine, is there a need for an in-person physical exam? Outside providers are prescribing and treating with buprenorphine over telehealth only.
Yes, so all patients enrolled in an NTP, regardless if you're receiving buprenorphine or methadone, are required to complete an in-person physical exam, which includes serology and other lab testing considered clinically appropriate by the healthcare provider performing the examination. The only portion of that may be declined by the patient, again, is the lab testing, but it's still required to be offered by the NTPs. And then if the patient declines, then either a waiver needs to be on file that's signed by the patient, or the declination needs to be documented in the patient record.
Thank you for that. And another question is about dosing. If a patient misses 5 consecutive days of dosing, is a new order not required in that circumstance? Would the patient simply receive the previously ordered dose?
A new medication order is required when a patient misses more than 4 consecutive days of dosing for medication.
And I have a question regarding MUs. And the question is, so even though MUs are now allowed to provide same services as an NTP, are you saying we must submit a 5135 with clinic layout to request this to be allowed for each MU before we implement this?
Yes, so MUs, they may provide the full array of NTP services as long as they have adequate space to provide the services in a confidential manner. So the primary NTP is responsible for ensuring that patients have access to all treatment services that are not provided at the medication unit. To provide additional services, the currently licensed MU, they do have to submit that 5135 and clinic layout that you mentioned to DHCS for review and approval before actually commencing any additional services in that MU. And then for NTPs that are wanting to open up a new MU, then the initial application form must be submitted along with supporting documents and the initial application fee as well.
And we have a question requesting clarification about the counseling session time. And the question is asking, does counseling sessions have to be 45 minutes now instead of 60?
Yes. So we want to make it very clear that counseling is a required NTP service, and we did update the language in this bin that an NTP must offer each patient at least 45 minutes of counseling services per calendar month instead of 50 minutes. So the NTP will create a care plan, with shared decision making with the patient to determine how much counseling is clinically appropriate each month for that patient. The duration of the counseling services are no longer required to be provided in 10-minute intervals. We took out that language in this bin. And we did that just because our sister division, the local governmental financing division, they're in the process of releasing a behavioral health information notice that allows for, I believe, 15-minute intervals. So we revised our regulations to go from 45 to 50 just to streamline things for you all. So I'll have to reach out to the local governmental financing division to obtain status of that bin, and then I could share it with you all as soon as we receive it. But again, the amount of counseling required to be offered is 45 minutes, but it's really decided on, shared decision making with the patient. And it's really important because, counseling helps NTPs to help patients achieve their goals. NTPs may provide other support, such as vocational, employment, educational, and harm reduction services that help that patient, achieve a sustainable recovery.
Great. And we have another question going back to the CSAT. And the question is, do you have to get a CSAT when using take-home flexibility?
So an NTP only needs to submit a CSAT exception if they're wanting to provide take-home medication that exceeds the supply limits that are outlined in both state and federal law. So the CSAT exception is required if you're exceeding those limits, just because we mirrored the supply limits that are outlined in federal law. And then supply limits, those don't apply to take-home buprenorphine. So just to make it clear, the supply limits on take-home medication for methadone are during the first 14 days of treatment. The take-home supply shall not exceed 7 days. From 15 days of treatment, the take-home supply shall not exceed 14 days. And then from 31 days of treatment on, the take-home supply cannot exceed 28 days. So if you're needing anything beyond 28 days, that's always going to require a CSAT exception.
Thank you for that. We have another question about drug testing. It's asking, is drug testing required for the new order for readmission after 4 missed days?
No, a drug test is not required after missing 4 days of medication.
Thank you for the clarification. We have a question about counseling services. The question is, are counseling services able to be provided via telehealth? Does this include video and telephonic?
Yes. So counseling services may be provided via telehealth, including telephonic. So we removed the reference requiring face-to-face counseling sessions under section 10345. So if you decide to implement before October 1st, once your protocols are approved by DHCS, you will no longer need to submit a facility-wide exception to provide counseling services via telephone. And then on the effective date of this bin, which is October 1st, no NTP will need to have an approved exception on file to provide counseling services via telephone.
And we have a question about the billing increments change. The question is, when did the billing increments change from 10 to 15? When are we supposed to start billing services in 15-minute increments?
So this webinar is specific to licensing requirements, and billing is handled by our sister division, the local governmental financing division. So I'll have to reach out to our sister division to obtain that behavioral health information notice number, including the effective date, to share with you all. We want to make sure that we reach out to the folks that oversee billing, so that way we can make sure that we get you accurate information.
Thank you for doing that. And the next question is asking to repeating the answer to a previous question regarding if there are any requirements for specific blood testing at the initial intake physical exam.
Yeah, so to clarify, the full medical examination during intake includes optional screening for infectious diseases, including tuberculosis, HIV, viral hepatitis, and sexually transmitted infections. In addition, the in-person physical examination is required to include serology and other laboratory testing considered clinically appropriate by the healthcare provider performing the examination.
And we have a question about split dosing here. The question is, will split doses need to be approved through DHCS?
No, split dosing does not require DHCS approval. The regulation was updated to specify that the dose may be split into 2 or more doses. So approval is no longer required.
Yes, and then I also wanted to add that just a reminder that a split dose is considered a 1-day supply of take-home medication. So just make sure that when you are providing split doses that you're taking into consideration the take-home supply limits and criteria.
Thank you. And it looks like we have time for one final question. The question is, can counseling services be provided directly from the MU? If so, does the MU have to become DMC certified?
Yes, the MU may provide counseling services, and as far as DMC certification, I'm not sure, but questions regarding DMC certification are outside of the scope of this webinar and will be addressed in the FAQ.
Thank you. And thank you both for answering these questions submitted by the audience.
And I just also wanted to share that we are also working on a FAQ that we will share with you all. So now that we have a good gauge of what questions that you all have regarding these new NTP law changes, we will make sure that we address questions that were asked here, and then maybe any questions that we didn't get to in that FAQ, and then we'll ensure to circulate that and share it with all of you. Thank you, everyone. Have a good day.
Thank you. Thank you for attending today's webinar. If you have any follow-up questions, please do not hesitate to email dhcsntp@dhcs.ca.gov, which you can see on your screen right here. Thank you all.